Hello, my name is Patrick. Today I'm going to explain the difference between aortic aneurysm and aortic dissection. All right, so whenever you're looking at situations like this, the first thing you want to ask yourself, what is aortic aneurysm? So this is an abnormal dilation of the aorta, and this is due to weakening of the walls of the artery. So for those of you who do not know, the aorta is the largest vessel in the human body. So when it is abnormally dilated due to the weakening of the artery, that is simply known as aortic aneurysm. Okay? So now we know what it is. The next question is, what causes it? What are the causes of aortic aneurysm? The number one cause is hypertension. If you forget everything, always remember that the number one cause of aortic aneurysm is hypertension. Of course, you can have other causes such as atherosclerosis, infection, trauma, and connective issue disorders such as Marfan syndrome. But the number one cause is hypertension. So now we know what it is. We know what causes it. The question is, who is more likely to get it? In which population are you likely to see aortic aneurysm? The answer is you are likely to see aortic aneurysm in men versus women. So it's more common in men. In fact, the ratio is 10-1. This is one of those moments when women have beaten you guys. Okay? I'm sorry for men. Women have upper hand in this case. Okay? So the ratio is 10-1. All right? Like I mentioned, there are other risk factors that can predispose you to aortic aneurysm. You can have hypertension, uncontrolled hypertension, atherosclerosis, it could be diabetes, it could be hyperlipidemia, it also could be smoking. Smoking is another important risk factor that you want to keep your eyes on. So we know the cause, we know what it is, we know who is more likely to get it. The question is, what are the symptoms? How would somebody present that will make you start thinking aortic aneurysm? So this is important. Sometimes it may be asymptomatic, and that is the case with lots of medical conditions. Sometimes you might not feel anything. There may not even be a symptom. I remember back in those days when people used to go for checkup, I didn't really understand why, right? We thought it was an exercise of those who had money. Of course, I understand the cost implication. Some of us do not even have money to go to hospital when we are sick, let alone when we don't have any symptoms. But the importance of checkup is that you get to discover something that you have, even though the symptoms may not have manifested yet. In the case of aortic aneurysm, it could be symptomatic. And that's one thing I want you to keep in mind. Just because you haven't started feeling sick yet does not mean you are healthy or something is not wrong. So most of the time, aortic aneurysm could actually be asymptomatic. You will feel fine, but something is happening inside your body. Sometimes it can be very painful, and it can lead to ischemia or thromboembolism. And sometimes if you leave it without doing anything about it, it can rupture. And when it ruptures, it can lead to death. And that's an emergency. So we know what it is. We know what causes it. We know who gets it. So the question is, how do you diagnose it? Right? You're thinking along the line of aortic aneurysm. How do you establish the diagnosis of aortic aneurysm? So the diagnosis is made by imaging test. You can do ultrasound, and you can do angiography. And this is very important. You need to have this understanding. So sometimes you take an exam or board exam or whatever exam you're taking, and they ask you what is the initial testing. the initial imaging test that you're going to want to do for aortic aneurysm is ultrasound. Now, if they ask you what is the gold standard, it is angiography. And this is important because sometimes in medicine, the gold standard may not be readily available. So you go with the one that is easily accessible or readily available, but can still get you the quality of the information that you're looking for in order to be able to make the diagnosis. So again, imaging test, that's how you are able to establish the diagnosis of aortic aneurysm. Initially, you're going to do ultrasound, and then the gold standard is angiography. So you know how to diagnose it. You know what it is. You know the symptoms. You know the risk factors, the causes. The question is, what is the most likely location of an abdominal aortic aneurysm? You are likely to find this in the infrarenal aorta. So there's superior, there's inferior. So infra means inferior. You're likely going to see it at the infrarenal aorta. So at the lower portion of the aorta. So the next question is, what size of the abdominal aorta? What size of the abdominal aortic aneurysm will make you get a vascular surgeon on the phone? If you check the size of aortic aneurysm and is greater than and is 5.5 or greater than 5.5, you need to get them on the phone. If it's 5.5 centimeter in size or greater than 5.5 centimeter, you need to get vascular surgeon on the phone. We don't want it to rupture. So what about what if you check the size and it's now 5.5? What then do you do? And this is a very important question, and they like to ask questions like this. You need to follow up. So if the abdominal aortic aneurysm is less than 3 centimeter in diameter, you do not need follow-up. You do not need immediate follow-up. So no further follow-up in the near term. But if it is less than 3 centimeter, but is greater than 2.5 in diameter, you need to do another screening after 10 years. Now, if it's 3 to 3.9 centimeter in diameter, you need to follow up every 3 years with ultrasound. If it is 4 to 4.9 centimeter, you need to do an annual follow-up. So this is important. So once it hits 5.5 or greater than 5.5, you need to get vascular surgeon on the phone. If it's less than that, you do mostly follow up with ultrasound. I hope that is clear. So we already established that. We know what it is, what causes it, the risk factors, who gets it, how to diagnose it, the location, and what to do in terms of follow-up. Who you get on the phone when the size is alarming. Now the question is, what is the screening recommendation? Right? So in medicine, it is always advisable that you catch the problem before it becomes out of control, right? Before it gets out of control. So who do you screen? The recommendation is that if you are a male and you are 65 years and above and you have ever smoked, so 3 things. You are a male, you have smoked, you're 65 years and above, you need to be screened for abdominal aortic aneurysm, period. That's the recommendation. So what if this aortic aneurysm has now ruptured? What do you do? That is an emergency. You need an emergent surgery to be done. No waste of time. All right. I hope this has given you a good idea, a synopsis, right? So when somebody sees you, what is an aortic aneurysm, you are able to tell what it is. abnormal dilation of the largest vessel in the body, which is the aorta, right? And you are able to tell them what the risk factors is. The number one cause is hypertension. You're able to tell who gets it more between men and women. What is the ratio? 10-1. You are able to explain the causes: hypertension, atherosclerosis, infection, and so on and so forth, right? You're able to explain how you diagnose it, when to get vascular surgeon on the phone, and all those important information, right? So now, what is aortic dissection? Aortic dissection is when the largest vessel in the body, which is the aorta, when it ruptures. That's the tearing of the aorta. When it tears, that is called aortic dissection in a simple term. How do these patients present? These patients are going to present with sudden onset of chest pain that radiates to the back. When you are reading a medical vignette and it says somebody has a sudden onset of chest pain and it's radiating to the back, you need to be thinking along the line of aortic dissection. Okay? So like I said, what is it? It is a serious condition in which there's a tear, okay, of the inner layer of the body's main artery, which is the aorta. When the inner portion of the aorta begins to tear, when you notice the tearing in the inner layer of the aorta, that's aortic dissection. So we know what it is. We know how they're likely going to present. What is the most common symptom to watch out for? Again, you watch out for back pain, okay? Pain that can go to the scapula, for example. So that's what you want. And these patients are going to come in and they're going to tell you, I have this pain that is ripping and tearing pain at my chest. And it radiates to the back, a sensation in their back. And that should get you to start thinking aortic dissection. So we know what it is. We know how they're going to present. What if you do a physical exam? What are the things you will see that will suggest aortic dissection? You will see blood pressure and pulse differences between the arms and the legs. That's very important. There we will see blood pressure differences and pulse differences between the arms and the leg. You might see things like cardiac tamponade, you might see aortic insufficiency murmur, but you are likely going to see blood pressure differences. Okay? Another question is, and they like to ask this question, where does the aortic dissections, where do they most commonly occur? So I need to explain this very well. So the aorta, you can have ascending aorta and you can have descending aorta. So most aortic dissections happen in the ascending portion of the aorta. In fact, 60% of aortic dissection happen at the proximal ascending aorta. Okay? So that's important. What are the risk factors of aortic dissection? Number one, guess what it is? High blood pressure. So the commonality between aneurysm, aortic aneurysm, and aortic dissection is high blood pressure. And I cannot emphasize this enough. It's really imperative that you keep an eye on your blood pressure. It can catalyze a lot of medical problems. So the risk factors for aortic dissection is uncontrolled hypertension. It is the most important risk factor. Again, you can have things like trauma, cocaine, Marfan syndrome, Turner syndrome, but the most important is hypertension that is left uncontrolled. So let's say you do an x-ray for aortic dissection, what are you likely going to find? You're going to find widening of the superior mediastinum. They always ask this question. You do an x-ray for someone, you suspect aortic dissection, you are likely to see the widening of the superior mediastinum. And you can see things like a hazy or enlarged aortic knob. All right? And you may also see like intimal calcification. But really, you want to keep an eye on widening of the superior mediastinum. What is the gold standard for evaluation of aortic dissection? The gold standard is MRI angiography. That is the gold standard. So another thing you also want to know when it comes to aortic dissection is the classification. There's something called Stanford classification of aortic dissection. You have Stanford type A, and that always involves the ascending aorta, but it could also involve the descending aorta, but mostly the ascending aorta. Then you have Stanford type B, which involves the descending aorta only. So Stanford type A mainly involves the ascending, but it can also involve the descending aorta. And then you have Stanford type B, which only involves the descending aorta. You also have this thing called DeBakey classification, right? DeBakey classification of thoracic aortic dissection. Basically, type 1 of the DeBakey classification it involves both the aorta, meaning the ascending and the descending. Type 2 only involves the ascending. Type 3 is just the descending. Okay. So now, another important question about aortic dissection that you need to really keep in mind is what aortic dissections can be treated medically, right? So the patients with Stanford type B, right, they are eligible for medical treatment rather than surgery. Okay, so the Stanford type B, remember the type B only involves the descending. Those guys are eligible for medical treatment only. They don't really need surgery. Okay, but the type A, which is the ascending, they are going to need surgery. Okay, so how then do you manage aortic dissection? So, number one thing, again, you want to control blood pressure. You lower the blood pressure. If it's type A, which is the proximal aortic dissection, it requires surgical management. Type B, which is the distal aortic dissection, that you can medically manage. Now, the other question is, which medication can be administered to lower blood pressure in a patient with thoracic aortic dissection? You can give sodium nitropyrazide. You can also give beta blocker. Okay, so you can do sodium nitropyrazide or you can do a beta blocker, things like labetalol. So when I was studying, I saw this question and I wanted to also explain it. Why does an aortic dissection lead to profound shock? This is a very important question. Why does aortic dissection lead to shock? So remember, because there's an injury to the tunica intima, which is the inner layer of the aorta. So there's an injury to that part of the aorta, right? It allows blood to flow between the layers of the aortic wall, and that forces the aorta to be apart, right? So blood flows into a false lumen and not into the systemic circulation. So long story short, because there's dissection of this aorta, blood does not flow as it should into the systemic circulation, and that can lead to profound shock. Okay, so what is the prognosis of untreated aortic dissection? So you leave the aortic dissection, you don't do anything about it, or what is the prognosis? Basically, 20% of those who have this aortic dissection will die within 24 hours. That's unfortunate. 60% will die within 2 weeks, and 90% will die within 3 months. Okay, but if they are able to get them to do surgery right away, they have 10-year survival. 10-year survival rate of 40%. So intervention is very important. Okay, as you can already appreciate from this presentation, this is something that can be very deadly. Okay, so the takeaway is to to be able to screen for it, control your blood pressure, okay, because that's the number one cause. And like I always say, if you know better, you do better. And we can talk about all these things about medicine. At the end of the day, the efficaciousness of the medication or the intervention is still contingent upon the patient, right? If I give you medication and you revert back to the practices and the abnormal behavior that predisposed you to the condition, then whatever it is I'm giving to you or prescribing is not going to make any difference. So I hope you have learned one or two. I hope you are now able to distinguish aortic aneurysm from aortic dissection. So I'm going to be churning out similar videos of two things that have similarity, and I'm going to be able to find and explain, the nuances and the differences. That way you are better informed, because I'm a strong believer that if you the quality of the decision that you make is always contingent upon the information within your disposal. All right, thank you for watching. If you haven't already subscribed, I encourage you to do so, because you definitely will be able to learn one or two things. Even if you are not going through this, you may have somebody who's going through it. You may have a family member, a friend, and the information can always be helpful. All right, thank you. Stay healthy, stay blessed. Okay, bye.